All right. Good afternoon, everybody. My name is Kate Papp. I'm a clinical neuropsychologist at Mass General Brigham. I'm an assistant professor of neurology at Harvard Medical School. And I'm also a member of the Massachusetts AI and Technology Center for Connected Care in Aging and Alzheimer's Disease Research. I'd like to welcome you to our webinar today, which is entitled Novel Technological Approaches for Detection of Cognitive and Functional Impairment. We have three excellent speakers lined up: Eric Larson, Jennifer Stamps, and Michael Milburn. And each of these speakers is an awardee from Mass AITC for a pilot project, and they're going to be presenting on the research they're doing. So prior to jumping into the session, what I'd like to do is just spend a few moments giving an overview of what our plan is for the next hour. So first off, I would like to provide an introduction, level setting for those on the call about the importance of using novel technological approaches for detection of cognitive and functional impairment, and sort of why this is important, why this is relevant, and what the advantages and also limitations of this approach is right now. And then we'll have our three speakers will be presenting for 10 minutes each. First, Eric Larson's going to be talking about testing a vocal biomarker platform for detection and monitoring of cognitive impairment. Jennifer Stamps will then be presenting on expanding a multimodal VR fitness platform to remotely assess, monitor, and report cognitive and physical function for older adults. And then finally, Michael Milburn will be discussing utilizing the Druid Impairment app to assess and enhance senior adults' driving performance. After each of our speakers presents on their projects and their approaches to detection of cognitive and functional impairment, we're going to have a Q&A session, which I'm going to take part in, as well as our expert, Rhoda O, who's a professor at Boston University and spends a lot of time thinking about digital cognitive and functional assessments. And we would welcome any questions from our participants today in the chat. Feel free to put them in the Q&A or the chat function, and we'll try to monitor those as we go along and try to address those during the final Q&A session. So before we begin, I just want to pose the question, why do we use technology, or why is it relevant now to potentially use technology to detect cognitive and functional impairment? You know, typically within our healthcare setting, when we diagnose people with dementia, mild cognitive impairment, some sort of syndrome that is leading to their cognitive and functional difficulties, it's a very involved process that involves, a multi-hour assessment within a clinic. These are hard to come by, waiting lists are long, and it's a challenge to use this traditional approach of one-on-one in-person assessments and testing, especially in the landscape where there's an increasing older population that needs services and needs to be diagnosed and tracked more efficiently. So there's a lot of advantages to potentially using technology. A major one is because these things can often be done remotely, there's a real increase in the opportunity for accessibility so that we can reach more individuals than we are able to reach in the setting of a clinic. These can be done unsupervised, unlike our clinical assessments, which are done one-on-one. They're very labor and cost intensive. Whereas the technology can really remove that supervision component. Also aligned with the question of accessibility is scalability, that we're able to reach many more people for these types of assessments. And this has great implications for research, particularly as we move into earlier stages of detection at earlier stages of the disease of dementia. And that's highly relevant for us to be able to perform large studies in at-risk populations rather than just smaller studies in symptomatic individuals. The ability to more easily collect data allows us to also collect it at more frequent intervals, which might really increase our ability to sensitively track change over time. And then some of these approaches are potentially less or more unobtrusive, especially passive monitoring approaches, than our typical overt cognitive testing. This really has the potential to reduce test anxiety and also potentially get measurements of cognition and function that are more ecologically valid or more relevant to everyday context across multiple time points. There's obviously still some disadvantages and kinks that need to be worked out. Of course, questions around data fidelity. Is the person who's doing the assessment the person who we think is doing the assessment? Yeah, even though we have a more ecologically valid environment when we test in the wild, it is the wild. And so there's a lot of uncontrolled elements, and a lot of these pilot projects that we're going to be hearing about today are addressing some of these seeing whether their assessments can really, work out in the wild. Technical problems that we run into with technology. There's variability across devices and operating systems. And then also user acceptability and digital literacy. So our participants or patients willing and able to use this technology if it's offered to them. So with that in mind, I'd like to get started. But before I hand it over to our first speaker, I would just like to note that we do have another webinar that's coming up on March 26th. There's a QR code here that you can scan if you'd like. And this is going to be on healthy aging in a digital world, promoting caregiver health and well-being. And this presentation is going to be by Heather Young. But without further ado, I would like to introduce our first speaker here. I'm just going to stop sharing. And our first speaker is going to be pulling up their slides, Eric Larson from Sondi Health.
My slides should be visible. Thanks a lot for the opportunity to present, and thanks to Mass ATC for sponsoring our pilot in testing a vocal biomarker platform that I'm going to be telling you about for the next 10 minutes. This is work that Sond is conducting in collaboration with Mass General, particularly Brad Dickerson and Bonnie Wong of the Frontotemporal Dementia Research Unit. And I'd like to start just with a few slides of context. Vocal biomarker technology may not be familiar to everyone, so I'd like to set the context. Sond Health was founded close to 10 years ago with the intent to build digital tools that could help people, essentially arm people with the information to help them stay healthy, be more proactive and aware about their health. It's kind of getting to the point where, as when you are driving across the country in a road trip, you won't want to check your instrument panel 5 or 6 times at random for a few seconds each, whereas that has been the traditional approach to healthcare, where we don't really know what's going on with us most of the time. With the advent of technology and the advantages that Kate just highlighted, we do know that there are potentially a lot of approaches we could take to start addressing these shortcomings. So at Sond, we made the decision to do this by analyzing voice and speech. And the inspiration here is that at that time already we knew from academic research that there was good potential in that area, and of course we know that people, in particular mothers, and to varying degrees doctors, also can do this. They're quite finely attuned to listening how we sound, particularly if we know people well, and being able to tell if something's not wrong with them with some degree of specificity, right? Whether they might be feeling depressed or that have a flu or an allergy. So the task is for technology companies to mimic this capability, maybe even exceed it, and build technology around it that can work in the real world. Now, fortunately, it is speech and voice are very rich signals. It's a benefit of the complexity of speaking. It is one of the more, or maybe even one of the most complicated things that humans do. The planning and production of speech and the rapidity and precision with which that needs to happen also means that it can be dysregulated in different ways with different either physical or mental conditions. Clearly, I think everybody intuitively understands that cognitive impairment will impact speech production and perhaps voice as well. But there's other conditions, clearly. The other advantage is that by using voice, we can make use of many of the devices that we are already using in our daily lives today. Smartphones are a very obvious tool. The smartphone apps, and that's certainly been our primary vehicle to deploy the technology. But there are more and more devices with microphones that are also being equipped with, let's just say, smart capabilities, headphones, earbuds, hearing aids, smart TVs, smart speakers. We're even working in vehicles. We've deployed our technology on most of these platforms.
Three colors of this and three blocks.
There's some background noise. Maybe somebody can mute. And so it's also an accessible and practical technology from that perspective. So moving on to this pilot project, this is part of what is currently our largest clinical research and development area. We have already launched products in respiratory impairment and mental fitness. But since about 2.5 years ago, we have started working on cognitive impairment detection in older adults. That has come about through a collaboration with GN, which is a global hearing aid manufacturer based in Denmark. They are very forward-looking and have a strategic focus on brain health. This is, of course, coming because of the increasing knowledge that we have that people with hearing loss, which are typically also older, are at very high risk for developing cognitive impairments. And so building in technology into hearing aids that could potentially help people to monitor that makes a lot of sense. So we have started a number of clinical programs and collaborations with various academic medical centers in the US and India to collect the data that we need to identify the vocal features that are necessary to build tools to detect or monitor cognitive impairment from voice. And typically how we do this is to collect large health-labeled voice biobanks that can be used with machine learning, different statistical techniques to associate what is essentially a large library of voice acoustic features with the health labels of interest. And that requires large data sets. We've made good progress in collecting those data sets and are planning to perhaps release some initial versions of models that can detect cognitive impairment. And the mass AITC pilot plays a unique role in this overall program because whereas the other 3 studies are aimed at collecting the relevant data to build up our knowledge of what voice aspects are related to cognitive impairment in clinical settings, the pilot study takes this technology and tests it in the home environment of older adults so that we can actually test what Kate mentioned as the potential disadvantages of this technology, right? So the uncontrolled environments, the usability of the technology, potentially less quality, ability of the target population to use it. We had not, before this project, really worked in older populations. So that was a question as well. And so what we are doing in our pilot with NGH, and we are a few months away from completing at least the enrollment phase of the pilot, is to enroll patients from the frontotemporal dementia research clinic at Mass General, and then including some cognitively normal age-matched controls, and have them use our research app to collect the type of voice samples that we need to do the sort of detection and monitoring in their home environment repeatedly over a period of at least 4 weeks. And then determine how usable the technology is, whether people actually engage with that and stick with the protocols, what the quality of the data looks like, and whether we can do some preliminary testing on actually whether relevant information is still contained regarding cognitive impairment in the signals we measure from these home environments. Just very briefly, what happens is our research app is installed on the smartphones of the participants, so they use it on their own devices, which can be any number of typical smartphones that people have, and they go through a series of different vocal tasks, some of which are very simple, very brief tasks. Other ones are actually cognitive assessments. As you can see, there are sort of just some general questions that would mimic natural conversations that people have. There are a couple of nonverbal tasks in there as well that are cognitive assessments, essentially. And people run through this protocol once weekly for 4 weeks. As of January of this year, we had enrolled about 30 out of a target of 50 of participants in total. Data collection is proceeding well. Roughly 1,500 voice samples collected. Feedback is being collected from participants at the end of the study regarding their experiences and usability. And we have started doing some data analysis with some candidate acoustic features and examining how those relate or don't relate to the diagnosis or the diagnosis status that the participants have. As I mentioned, we have some cognitively normal individuals. We have different types of cognitive impairment, ranging from MCI to behavioral variant frontotemporal dementia, PCA, and PPA, so that we represent a range of cognitive impairment types. We've had good results on the goals so far. These are all interim analyses, so these are just early impressions of the data. We have good compliance with the protocol. We are getting fairly good completion rates during the 4 weeks of the protocol, which is in itself quite an achievement. We do other longitudinal studies in other areas, and as many people I'm sure will know, it's hard to keep people engaged in research studies. So this is quite positive. We've had in general favorable feedback from participants. We've definitely learned some lessons in terms of tasks or aspects of the app and the technology that are difficult to complete or use by participants, and we've made some adjustments. But in general, the app is very usable. People complete the tasks easily, and beyond expectation, many people have actually enjoyed doing it. They feel that these exercises are sort of brain games and activities and help them to understand what they're doing well or not, which they have favored. And some folks have said that they feel would be useful for their clinicians to have access to the data. In terms of other aspects of feasibility, the signal quality, which could be a concern when we're not in a controlled environment. We have a standard audio quality control process that we follow in all of our studies with trained staff, so a very standard way of assessing it. I won't explain the whole rating criteria here, but we have essentially well over 90% of the data is usable according to our regular quality control criteria. So that was also above expectation, I would say. And then we're getting some early indications that the actual extraction of vocal features is looking like it can be indeed helpful and predictive. We have just selected some obvious speech features not derived from any machine learning, but things like speaking rates, pause duration. We have some composite scores like mental fitness, which is really a mental health measure that we've used for convenience because it exists from other products. And we've visualized those as dashboards, being able to see how we could track whether participants are stable or not over time. And we're getting, we're getting sort of trends that look reasonable there. Certain things that look also interesting is when we look at some of these candidate features like speaking rate and pause duration, we can see that these vary according to the vocal tasks people are doing. Some of these vocal tasks are harder than other ones. So we know that people generally slow down, take longer pauses to find their words. We're seeing those trends very consistently in the data, which is in itself encouraging, again, that the data quality allows us to see those patterns. What's furthermore interesting is that we see marked differences between the cognitively normal and the cognitively impaired individuals, again, in ways that we would expect in terms of speaking rates and pause durations being indicating greater difficulties in the cognitively impaired population. I'm coming up on time, so I will just end with with some very preliminary analysis that is really not a rigorous assessment of prediction performance, but simply sort of a proof of concept analysis that just looking at a single speech feature, for example, speech rates across these 8 different vocal tasks and creating a norm of what rates you see in the norm, cognitively normal versus the impaired people, and then comparing each individual participant against those norms, we can already see that that kind of an assessment works quite well with sort of a 70% accuracy to determine correctly the diagnosis of the individual. Again, that needs to be taken with a large grain of salt, since there are no real controls in this analysis, but it's a positive indicator that we're getting usable information here. So we're looking forward to complete this data collection and then run through all of these analysis more rigorously, maybe present at another time when the work is complete. That's it. That's it for today. Thanks again.
All right, great. Thank you so much, Dr. Larson. So our next speaker is going to be Dr. Jennifer Stamps, who's presenting on the multimodal VR fitness. So we'll just pull those slides up now. And then while she's pulling them up, I just want to let you know that you can please feel free to put questions in the chat. We'll get to them at the end, but you're more than welcome to put them in as we go, and we will be helpful as well. Thank you.
All right. Well, thanks for coming, everybody. And it's nice to kind of meet some people, I guess, in the group. But yeah, so my name is Jennifer Stamps, and my background is well, I'm a clinical neuroscientist. My background's in basic neuroscience and also behavioral neurology. And then I ended up in biotech. But so I'll just get right to it. So I work for a virtual reality company that makes virtual reality platforms specifically tailored to the needs of older adults and making it accessible for older adults to use. And the focus of the company in general is just expanding worlds of people where life has become limited and helping them have meaningful social interactions to prevent functional decline that we deal with as we age. So so really what the company's focused on in general is just that, and also providing non-pharmacological solutions to pain, mental health issues such as depression and anxiety, and also behavioral and psychiatric symptoms in dementia. We are really, social health is a very important backbone to the company. that's kind of all the platforms revolve around that, around gathering people and creating real relationships through virtual reality. And we have lots of different types of VR platforms. We have an engagement platform. We were just finishing a large clinical trial with that, with UCSB. And this is our first, I guess, funding for our fitness platform, which we've just released not too long ago. So we built this fitness platform, and it consists of a Samsung tablet, and that's how you control the games and everything, and that's where you see your scores and can track your progress and things like that. And each system would come with 2 Pico 4E VR headsets and 2 elliptical desk cycles, and some external Bluetooth sensors if you have your own, to use with your own cycles, if you have them and you don't want to use the elliptical desk cycles for whatever reason. And it is the first virtual reality fitness platform to combine physical exercise with cognitive stimulation and the social engagement. And so by combining all three, we hope to just really improve the aging process. So we know physical exercise counteracts a lot of problems with aging and keeps people functional a lot longer and independent. The problem is compliance. Nobody wants to do it. And so making it fun and making it more of a social event where people can race or just go on bike rides together would hopefully improve compliance. So, and I'm just going to go a little bit faster. So, according to the NIH, studies show that physical activity among older adults reduces the risk of numerous diseases. And we're learning more about the aging brain every day. And we know the benefits of weight training for protecting against neurodegeneration. And we're hoping that combining the exercise benefits with combating social isolation at the same time, you'll have a double whammy effect and just really try to prevent some of the risk of premature mortality that occur with lack of activity and with social isolation. And so there's 3 modules in the Rendeavor Fit platform. And there's cycle. And by the way, just all 3 modules they were designed in a way that allows older adults with upper or lower extremity limitations to exercise safely and effectively. And were specifically chosen based on evidence of preventing cognitive decline, and are ones that are typically recommended in a neurology clinic to older adults. So cycle, we want to have something where they can safely get a lot of lower extremity exercise and leg exercise in to help stimulate production and circulation of BDNF, a neurotransmitter that helps with neuroprotection. And we see more of that in people that are cognitively healthy than in those who are not. And then we have ping pong, which is it's kind of funny. For whatever reason, lifetime ping pongers have larger hippocampi than people who have not been playing ping pong and are more resilient to cognitive decline. And there's a lot of other documented benefits to table tennis, such as mental acuity and better reflexes and balance and leg, arm, and core strength. And then paint, and that is where you can paint with up to 10 other people in a completely immersed canvas or an outer space. But wherever you are, you end up using your whole body to create works of art, and you can do that with other people. And it's just a way of promoting divergent thinking and strengthening frontal and polymodal and supramodal regions of the temporal and parietal lobes. So, and you can, individuals, when they go on to use Rendeavor Fit, they set up their profile the first time they use it, and they create an avatar for themselves, and they can track their progress over time. They have a dashboard that they can access with a password, and the fitness platform itself collects their usage data, their scores, and things like that.
Introducing Rendeavor Fit, the world's first virtual reality fitness game designed to get seniors working their legs, their arms, and their minds. RFit pairs virtual reality with cycling for an immersive physical and cognitive workout, making fitness challenging, social, and laugh out loud fun. In fact, Rendeavor Fit makes exercise so fun, players don't even realize they're working out. They're too busy laughing. Celebrated by Time magazine as Best Invention of the Year and recognized by industry leaders as the best fitness gaming platform for seniors, Rendeavor Fit studies show motivation and engagement doubled. And physical pain was nearly halved, as over 90% of participants said Rendeavor Fit made exercise more fun and rewarding. Rendeavor Fit has 3 different kinds of games for all different interest and skill levels. Every game can be played either in single player or multiplayer mode. Pong. One of our top games on RFit is called Pong. Participants hone their skills and develop their swing through target practice on a remote island. Over time, celebrate improved accuracy and watch as they climb through the ranks on the global leaderboard. Cycle. For those who enjoy a little friendly competition and want to get some bicycling in, our cycle game requires mind and body to come together as participants pedal through fantastical worlds where exercise is play. Pop balloons while cycling and get those arms and legs moving, compete for high scores, and enjoy the magical landscapes with friends. Everyone who plays cycle gets to create their own avatar, which they embody once they put on the VR headset. Here you can see what 2 players experience in VR as they bike play together through fantastical magical worlds. Paint. And for the creative artistic type, Paint makes it possible for players to create virtual 3D brushstrokes. Watch in awe as they move around their virtual canvas, creating a magical masterpiece that is too fun to feel like exercise.
They're doing it together, popping balloons. They're riding on this bike that they would probably ride for 5 minutes in real life, but you put them on this with the program, they forget they're exercising. They're just having fun, and they're doing it together.
So we did a pilot study. This is on shortly after we released this product, so it's already been commercialized, just as a fitness platform. And we did a pilot with Front Porch and USC, and they used it for there were about 10 residents from 2 different senior living communities that participated, and they used this Rendeavor fitness platform for 4 weeks, 2 sessions per week for 4 weeks, and we found significant improvements on the 3 functional tests that we included in this pilot, which was the time up and go, which is how long it takes you to stand up, walk across the room 30 feet, come back, sit down. And the tug manual, you do the same thing, but you're holding a glass of full water. And then the tug cognitive, you do the same thing, and you count backwards by either 7s or 3s, depending on if you have mild cognitive impairment or dementia. And there were significant improvements on all of those in the study. People also felt better about their physical health and abilities and their mobility, and their feelings about their physical abilities significantly improved as well. Another thing we saw was a big decrease in their fall anxiety and a decrease in the level of pain interference they got with daily activities and sleep. as well as a decrease in loneliness and an increase in trust of the other people that they exercised with. And we saw a 9% increase in movement speed in just that short time. But what's really cool is the compliance. So we don't see usage data slack off when it's been introduced into, mostly this is sold into senior living communities and physical therapy offices. And we don't see the usage data slack after a while, like a lot of exercise data you do. So that's been encouraging. Everyone thought it was a lot of fun and gave it very high user ratings. So it was easy for them to use, and they thought it was fun. And just to go over, but that wasn't enough. So our healthcare partners, they love that, and they love that their physical therapy patients were doing what they were supposed to in between their visits and exercising more. But what our healthcare partners were really asking for was help in the severe shortage they're having with providers, with doctors and physical therapists and neurologists. And what they asked us to do is to add on to this and enable remote assessment of their patients and monitoring and seeing their response to rehab, determining, if they're okay for surgery, things like that. Detecting any kind of cognitive decline, whether that's gradual or something very sudden that, they might want to check for a UTI or something. Just a way to remotely monitor their patients and to monitor more patients as they're kind of overburdened. So we applied for this grant to try to help build this thing out. And so the data that we're capturing is from the elliptical cycle. We get the time spent in that they're cycling, the speed, the distance, the calories they burn. From the Pico 4E VR headset, it has a pretty fast refresh rate. We're capturing a lot of data every second. We've got 6 degrees of freedom positional tracking to track body movements. There's eye tracking in the headsets, so you can do things like, measure the time it takes someone to look at a target and then pop the balloon with their hand, go to move their hand. You can look at their horizontal and vertical saccades. You can measure attention, things like that. And then the headset also has face tracking, so you can, so the avatar can actually display the correct facial expressions. But that also allows us to detect things like mask-like face or an asymmetrical paresis, a droop from stroke. And then there's also hand tracking. We can look at things like tremor, reach.
Dr. Stamps, just in the interest of time, I don't know if you can just wrap up so we can.
Yeah, I'm about finished. So yeah.
Great.
And then the game scores themselves are collected as data. And anyway, and there's a dual task assessment built into the cycle that's very helpful for things like that, for measuring function. And then so our approach to gathering the data is we're recruiting is decentralized recruitment to help have a representative sample, and we're recruiting 30 dyads of people with mild cognitive impairment to moderate dementia who are also physical therapy patients and have a live-in caregiver. And so the care recipient and caregiver participate together. They'll be doing this together in their home 5 days a week for as many minutes as they're prescribed by the physical therapist, and use the whole game. And we'll be gathering all that data on them as they're exercising. If within the first month, if they fail to comply to their exercise program and we're not getting the data we need from them, we have them send the the system back and we recruit another dyad to replace them. And then we do data collection of standards, functional and cognitive standards alongside what's being collected in the platform, so that we can build predictive models. And at baseline, we do a whole core of cognitive.
I think we're going to have to just move to the
Okay.
next speaker.
That was my last one, so we're good.
Okay, thank you so much for sharing the progress on the work that you've been doing with this fitness platform. So our last speaker is going to be Dr. Michael Milburn, who's going to be talking about senior adult driving performance.
Okay, good afternoon, or whatever time it is where you are. I'm Mike Milburn. I'm founder and chief science officer of Impairment Science. Bill DeYoung, who's our vice president for research, and I put together this grant along with some folks from the UMass Amherst Human Performance Lab. The main goal of our pilot program was to determine whether the Druid impairment app that Impairment Science has developed to measure the extent to which that can correlate and predict with various measures of driving performance. So our plan, and we're still waiting for IRB approval, is to hopefully start collecting data in March. We're going to recruit, try to aim for 40 senior adults, age 65 to 85 or so. We may end up recruiting 60, because one of the things we have to account for is simulator sickness, that some people get really disoriented, particularly older adults, when they're using a driving simulator. And so we're basically, it's a fairly straightforward study. We're going to have people come into the Human Performance Lab, sit and do the driving simulator, and also do our Druid app. The Human Performance Lab driving simulator is very cool. And we're in the process of developing, or pretty much have developed at this point, a series of short, 1 to 2 minute driving scenarios where enabling the participants to take a short break in between, again, to sort of minimize simulator sickness. And the driving simulator measures a whole host of variables. And as you can see, longitudinal, lateral velocity, braking force, reaction time, errors, and how their visual gaze is oriented. We're going to take all those driving simulator measures and connect them with with a number of variables, the multitude of variables that the Druid app also collects. This was originally created in response to the legalization of cannabis in Massachusetts, where politicians and police were saying there's no way to measure impairment from cannabis. And I thought, with a background of 40 years of college research and teaching, with a specialty in research methods, measurement, statistics, I thought, well, I bet I can do that. And so identified the main aspects of cognitive motor performance that are essential for driving, and other tasks as well, but for driving, and that get impaired by cannabis and alcohol. So reaction time, decision-making, hand-eye coordination, and balance. And so currently Druid has 2 different versions, a rapid version that takes a minute and a benchmark version that takes about 3 minutes. It's available on all iOS and Android platforms. And the software in the app takes the hundreds of data points that are generated by using the app and calculates a single total impairment score. The app itself, as I like to say, is elegant in its simplicity. There's 4 different tasks. The first task is, we say, decision-making and reaction time. 2 different shapes, a circle or a square, is presented on the screen. and also has two phases, phase 1 and phase 2. But the first phase, there's going to be a target shape and a control shape. So the target shape is, if they see the target shape, let's say it's a square, they have to hit the square, and it only flashes for half a second. They have to tap the screen where that square flashed. If they see a circle, instead they tap the white oval at the top of the top of the screen. So reaction time and errors of choice and distance are measured. The second task is oh, and I should say the first 3 tasks are all divided attention tasks, so require people to do a couple things at the same time. Obviously important for driving, look at the speed down the road, yell at the kids in the back seat, as well as a capacity that gets impaired, the ability to perform divided attention tasks get reduced by the consumption of substances like alcohol and cannabis. Task 2 requires people to estimate the passing of either 15 or 30 seconds while they hit the screen where they see circles flash. And again, reaction time and errors of choice and so on are measured. The third task is hand-eye coordination. So a circle appears on the screen, it starts moving when they touch it, and they have to keep their finger on the circle as much as possible while they are counting the number of squares that flash on the screen. And then finally, the fourth task is the single leg stand from the standard field sobriety test, which is important. Somewhere between 50 and 80% of the neurons in the brain are in the cerebellum, which control balance, but also a whole variety of other capacities, including various aspects of cognition. And so we make use of the accelerometer in the devices to measure movement like that. Built into the app, if you do it repeatedly in a relatively short amount of time, it tracks how your impairment changes, if it is changing at all. And so here's a participant who had a baseline of around 40. All right, so scores run from like 30 to 70. A higher score is higher impairment. A score of 55 is around equivalent to the average impairment for people with a blood alcohol concentration of 0.08 or more. And people typically have baselines between 30 and 40, sort of low 40s. We have multiple peer-reviewed validation studies that have been published. One of the first things I did was to try to calibrate the app to impairment associated with blood alcohol concentration. So I developed this app as a tool of personal responsibility so people can be able to test their own level of impairment. I got cooperation from various different municipal police academies in Massachusetts, where they conduct wet labs, where the cadets in the academies bring in volunteers who will drink alcohol to get their blood alcohol content above 0.10 or so. And then the cadets can practice the standard field sobriety test with actual drunk people. So these volunteers did Druid before they started drinking, and then after they reached the target BAC, and you could see the average Druid scores are dramatically different. We had a wildly significant, t-test value there. So very effective in determining and assessing impairment from alcohol. We did have a grant, a Small Business Innovation Research grant from NIDA, from the National Institute on Drug Abuse, and it funded a study at Johns Hopkins Medical School, where they had participants come in, to the lab 6 different times, 3 times consuming cannabis with a volcano vaporizer, 3 times eating a brownie, and their research showed that Druid was sensitive enough to distinguish different levels of impairment from different amounts of THC that a person consumed. So we're really quite happy with the sensitivity that the app can provide. And our basic approach is that we think cognitive motor impairment should be assessed by measuring cognitive motor behaviors, which is what the app does. And a third study, we actually collected data from daily cannabis users, and we were able to identify impairment in that population as well. The Johns Hopkins study was of relatively infrequent cannabis consumers. Now, Druid is essentially like a fever thermometer. If your temperature goes up, you know something's going on, but it doesn't tell you what's the source of that fever. Druid is the same way. If there's an increase in scores, and people can develop a stable sort of baseline score, if there's an increase in their score, that indicates that something's going on. We're obviously very confident that it assesses impairment from impairing substances like alcohol and cannabis. It turned out we've been able to assess impairment from fatigue, but also one of our interns had a fall, developed a concussion. She had a very stable baseline of about 34. After the concussion, as you can see, her Druid scores approached 65. And then gradually, and she was doing Druid 3 times a day. And so gradually over the weeks, her Druid score went down, back approaching her baseline score. The doctors cleared her, but she had actually started with a more demanding job. And so her Druid scores were showing that she was not fully healed from that concussion until about 12 weeks or so. So that it's really clear evidence that Druid is a sensitive measure of impairment and able to assess impairment from a variety of different sources. So we are really planning, let me see, so we'll be looking at a whole variety of different measures from the driving simulator and from the Druid score. And we think that Druid is going to be a very useful tool to promote healthy aging and to help seniors make decisions about their driving performance. So.
Great. Thank you so much, Dr. Milburn, for that presentation on the Druid. I think we unfortunately don't have as much time as we had anticipated to answer or to have a discussion, but I think that we should, ask some questions just to begin. And if folks from the audience have questions, please feel free to put them in the chat or raise your hand. I think Rhoda, Dr. O, does have a question for generally for the speakers. If you'd like to ask that just to start us out, Dr. O.
Yeah, great. So those were great presentations, very interesting work that you're all doing. And as all of you know who've been in this technology space and are developing all these great new tools, one of the questions, though, that comes up is, what are now the barriers that you foresee in order to get much more widespread uptake? Within, because you have clinical applications, you're trying to get the law enforcement agencies to pick this up. So where do you see some of the challenges for you going forward in order to bring your technologies at a scalable level into the general population?
Well, I know in the case of Druid and impairment science, there are existing ways to assess impairment that law enforcement or companies use. And so there's a lot of inertia in making a change. Workers have their fake urine, police have the way they do things. And so there's inertia there. And so it's just what Druid is really offering is a paradigm shift in how cognitive motor impairment should be viewed and should be measured. And those kind of paradigm shifts don't happen easily. And so I think that's a question for anyone who's really a potential issue for anyone who's measuring impairment.
Dr. Larson?
Yeah, I think in our area, one of the key barriers has been validating the technology. And regardless of whether this is truly used for clinical medical purpose, even if it's used for a wellness purpose, the partners that would take up this technology and integrate it into their products, they want to know that that what we're doing is valid, right? So it doesn't only necessitate research in a controlled setting where you're collecting data, post hoc analyzing it, but that actually that this in users' hands, people can use it it still delivers valid results, and that it's a compelling sort of product value proposition. We have been able to demonstrate that in our previous products, and so I think some of those barriers are getting addressed now. We'll have to do the same for this in the cognitive space as well.
And speaking generally of barriers, I know another issue that has come up working with older adults has been around questions related to data security and sharing data. Are those things that you, I don't know, any of you of our speakers have run into, or how you've potentially talked with participants or users about those risks or mitigated them?
Well,
go
ahead.
sorry, go ahead.
I was just gonna say, on our end, we're kind of in uncharted territory in some ways, because they can, I mean, the data we collect, the usage data and everything that we collect on them, of course, we would never share it with a third party of any sort. We don't do any of that kind of stuff with it. It's all encrypted, and it's all HIPAA compliant as far as we keep it. But if they use their real name for their profile or something like that, or if they import photos and videos onto their profile, that's kind of their choice. And it's hard, it is difficult to navigate, because you'll tell them, you'll explain to folks, this is up to you. We have on our end, everything's HIPAA compliant and safe. But if you choose to display yourself, your real identity and things, that's on, you just have to educate them. But yeah, it is a sticky area when you're wanting to get individual data from them, but also protect their identity. And some of it's a social platform, where there's multi-players.
All our data end up being anonymized and encrypted. So, and it's not even HIPAA data, since it's just performance on a video game. So,
in our case, we it's different in research studies, of course, but for our products that originally were developed on cloud platforms where their data is being transmitted, that we have now developed that technology to run on local devices, right, whether it's a smartphone or another device. So first of all, no data transmission takes place. We don't even actually store the audio on the device, because the analysis happens in very short segments of audio. That audio is not even stored. So only sort of the analysis results remain, which are not identifiable, and there's no danger of that being intercepted anywhere. We also use voice identification to not have other people's data be analyzed at the same time.
Well, thank you each for that, and thank you each for speaking today. We're going to have to wrap it up because we're at the top of the hour here. Unfortunately, we didn't have more time for discussion, but it was definitely interesting hearing about each of these projects, and looking forward to hearing updates as these different projects move along. And thank you all for joining us for this webinar on cognitive and functional assessments using new technology. Thank you.